Morning, everybody. I'm just waiting for the slides to come up on your screen.
Oh,
can you
excellent.
hear me? Can you?
We've got the slides.
Oh, great.
This looks really good, Gary.
Thank you. So it's it's a double privilege to be here today, and a double pleasure. I think I'd like to thank the organizers for the invite. It's always a pleasure and a privilege to present, and thank you for that opportunity. But also, as other speakers have intimated, it's a great pleasure. Like my second pleasure is to be here as part of this celebration of Dr. Ruddy's career and the work that he's been involved with in Ottawa. And I think this topic is very close to his heart. I think he's managed to educate a huge number of nuclear medicine residents, cardiology fellows, both national and international. But as well as being close to Dr. Ruddy's heart, I hope that this topic is also close to your own. I'm sure there's many in the audience that are involved in the education of residents and fellows, and I hoped that by talking about this, it would provoke some conversation during the panel discussion. So back in 1996, the late Barry Zaret was writing an editorial, and he commented on these 4 criteria that defined a thriving field within clinical medicine. He said that a thriving field in clinical medicine should have an appropriate knowledge base, and that knowledge base must be grounded in scientific principles, and that knowledge base, which was grounded in scientific principles, should be readily clinically relevant. But his last point in this criteria, these 4 criteria, may not have been one that sprang to mind easily, and that was those active in the field must produce what he called clinical offspring of appropriate type and sufficient number to ensure clinical and investigatory longevity. And I will put it to you that Dr. Ruddy has certainly done this during his career. I think the word in the middle of that phrase, must, implies an onus on us as educators, as leaders in the field, to ensure that we have lots of enthusiasm about what we do, to inspire others to take up what we've done and to carry our specialty forward. In the mid-teens, sort of 20-teens, the teenage years are always years of change, and it was no different in clinical education. Many colleges across the globe decided to adopt this CBME, competency-based medical education. It was no different in Canada. And the idea of competency-based medical education can be illustrated really by these 2 graphs at the bottom of the slide. This graph over here, I hope you can see my mouse. Can you see my mouse? Hopefully. Anyway, the graph on the left side, it says time-based curriculum on the x-axis. Although this is number of cases, I want you to really interpret the x-axis as time. What you can see is that competency was believed to be achieved once these individuals had read 150 ankle x-rays. And there was not much attention paid to this competency level on the y-axis. So we have an emphasis in a time-based system where you look at the x-axis. I want to contrast that with a competency-based curriculum where we pay less attention to the x-axis and pay more attention to the y-axis and actually define levels of competence. And so you can see from these 2 learners that one learner achieved competency after about 75 cases, and another one actually achieved competency much sooner after about 50 cases. So of course, number of cases or time is still important, but the emphasis switches to a y-axis in this relationship with a competency-based system. And the advantages of such a system are that we can, by defining those competencies, what are our targets for learning, we can better customize training. But also, if we look at learning as in terms of how and when learners achieve competency, we can detect deficiencies and maybe structure our teaching to tackle those deficiencies. It also enables transparency in assessment, and increasingly our learners are becoming more vocal about the length of their training, about the suitability of teaching, and about being treated very fairly, all of which are important. But having a competency and target where there are clear goals and aims becomes much easier for assessment to be transparent for both parties. The whole concept, though, of competency-based medical education is to lead to improved development, not just in terms of teaching programs, learning programs, but also, of course, in terms of clinical practice and acumen. So the Royal College has proposed that training residencies establish frameworks for all training residencies, and those frameworks are called competency by design, and you may have heard of those. I wanted to spend a couple of minutes just looking at the anatomy of the learning curve, because I think this is quite instructive. I think these learning curves are quite intuitive for those who've done practical procedures, but perhaps are less intuitive for those of us who look at imaging as imaging learning curves. So the concept is early on, there's a slow phase of growth, and that initial phase of growth could maybe just background reading and understanding. So for nuclear cardiology, that might be having some background knowledge about tracers, about the people we scan, about the type of images that are produced. And then you can see where it's a slope rate of learning. Perhaps this is the time when learners get exposed to actually looking at images, and they have a very rapid increase in their competency during those early phases when they first look at images and really begin to make connections between what they see and understanding how this correlates with coronary anatomy. And then there's an arrow here that says inflection point. And at that point, the learning becomes more effortful. Really, to make that last leap into the competency area, it takes a little bit longer, a few more studies to read, a little bit more thoughtful interpretation, a little bit more understanding about artifacts and the camera nuances that makes our days most interesting when we're in practice. Of course, this is a stylized learning curve, and the reality is much different from that. And you can see, again, this is looking at ankle x-rays, so a little bit easier to measure kind of competency on that. But these are multiple learning curves from multiple residencies, learners, residents. And I think the things that you can tell on this graph are, you can see that there are some who have very rapid learning and then maintain a very high competence. Those would be those residents and learners above the bold black line, which is the mean. And then you can look below that where you can see some very slow, particularly the bottom one, you can see a very, very slow initial trajectory, very poor learning. And then something happens around about 100 cases for this individual, and the trajectory changes and they improve dramatically. And these curves remind me somewhat of percentile charts from pediatrics. You remember when we did pediatrics, babies were weighed and measured, and then you got put on a percentile. And if they didn't stay on that percentile in terms of their continued growth and weight gain, then they were called, we recognize that those babies were not thriving. And there's an element of that, I think, in these learning curves. If residents aren't following a strong trajectory, then they're not thriving. And so the question is, how do we tackle that? So the Royal College of Physicians and Surgeons in Canada has identified within nuclear medicine 2 pathways that are suitable. There's a pathway of solid nuclear medicine training, and then a second pathway that has nuclear medicine and radiology. And in both of those, there's a heavy emphasis on nuclear cardiology, cardiac PET, and hybrid imaging, but in both pathways. In cardiology, our recommendations come from this COCATS training statement that was written by members from ASNIC and the ACC, and the first author was Vaskandilzian, but also I think some members of the audience took part in this, writing this document. And 3 levels of training were identified: level 1, level 2, level 3. And this table sort of summarizes those requirements. So level 1 was a minimum duration of just 2 months. Level 2, to be able to read clinically, was 4 months, and then 12 months for a fellowship training for level 3. And there's some ideas of minimal numbers of exams expected to be read during that time. And there are some small print details down here. But I think the striking feature to this table is that this is still based on the x-axis. So we discussed, the x and y-axis to those learning curves, and all these parameters are based on that x-axis. And I think the onus on us in the field now is to move into COCATS 5 or beyond and actually begin to use the y-axis and actually indicate where those levels of competency should be and at what stage they are. There is some evidence to support those numbers. This is data that Dr. Barrett Zarat was writing about in 1996 in his editorial. And you can see here in blue, you have trainees, and in red, you have the experienced readers. And so they looked in these trainees who had achieved level 2 training. They looked to see whether or not their levels of reads were similar to experts in the field. And they found that they were similar. This was based on 111 perfusion studies, spec perfusion studies, about 77 of which had gone for coronary angiography. And that there was about a 30% normalcy rate within this population. The issue with that data, though, is that it doesn't really assess learning. It shows you these trainees had already achieved level 2. There was no detail about, well, what do learning curves look like in nuclear cardiology? Are they similar to those learning curves that we saw from reading ankle X-rays? So we also saw, when we looked at those learning curves in ankle X-rays, that we know that there's a huge variation. And so again, that data doesn't really show us that variation. And that's important both to document how learning occurs, what the rate of it is, and how diffuse those learning trajectories are. There was also limited competency measures used within that study. So they assessed the ability of learners to be able to detect normal versus abnormal scans, which is clearly important, but they also looked at those who had angiography and then saw, well, what's the accuracy of determining single, double, triple vessel Ds? Again, important parameters, but we also perhaps nowadays might use percentage ischemia, some stress score, or other measures to measure competence against. So I think there's still a question as whether in a larger cohort, as we look to apply competency and competency-based medical education, are the current training volumes reasonable? So that paved the way to this paper that was headed by the last speaker, Dr. Chow, and but also by the rest of the group in Ottawa, and I had the privilege of taking part in. And essentially, what this paper reflected is in a large part is what we do on a day-to-day basis in the nuclear cardiology lab in Ottawa. So very briefly, what happens is that the learners will pull up the images. The cardiology residents, nuclear fellows will have their own stations, and they pull up the images, either a rest stress SPECT or a rest stress PET. They will interpret it, and they will write a clinical report. And then on a tablet, they will quickly fill out fields to indicate their interpretation. And that tablet report goes onto a network file. Then as staff, we will come and review the images with them, and we'll ask them to pull up their tablet report once we've finished our clinical interpretation. And we will correct that tablet report. And so it creates a staff tablet report and a resident tablet report. So there's two reports on the tablets. And that enables us to track learning. So we can see, after every 50 cases, we will evaluate, how are the learners doing, how are the residents and the fellows doing. And through that technique, you're able to develop some nice learning curves, just like we saw for those ankle radiographs. And I just wanted very quickly just to show you some examples of those learning curves to illustrate some of the finer points maybe of competency-based medical education. So one of the important things is to define what you mean by competence, and that's really what's shown in the orange, the green dotted line, and then the bold green line. And the way that the competence is defined is you have two expert readers and how often do they agree. So for some stress score, SSS, you can see the level of agreement was 0.89 or 89%. So if you take two standard deviations to allow for variation, either side of that, the lower end of that, so 0.79, was a lower level of competency. So this bold green line was a lower level of competency. And what we looked to is when do our learners achieve that, and this individual achieve competency after 150 cases if you use the sum stress score. But if you then look at using percentages LV ischemia, and you look again for expert agreement, here it was much higher. So as experts, we agreed much more quickly or more accurately or more with a tighter correlation. So it was 0.96 or 96%. So it was harder for our learners to achieve competency if you used LV ischemia as the measure of competency. And you can see that this individual, probably about 325 studies, achieved competency when LV ischemia was used. So some important points here, I think, in terms of understanding how this field may develop. So in total in the paper, we had 24 trainees interpreted just under 10,000 studies over 3 years, and a mean of 400 studies each. And just so that we're aware, there was about 20% of the studies were abnormal. So this table was important in the paper. If you look to the final column, trainee case volume needed. So on average, the number needed for competency for some stress score was 600 studies overall. And for LV ischemia, it was 800 studies. And the important point really about these numbers is that this is almost double the current level 2 training requirements. If you look purely at abnormal studies, and abnormal studies clearly are important in terms of our learning, then you need fewer, 200 studies for some stress score, 400 studies for percent LV ischemia. And the issue, as many of the audience will know, is that our number of abnormal studies has been steadily declining over the years. So, you know, although these numbers are a lot more attractive than the numbers above, to achieve that, you can probably do your own sums to see if these are actually accurate numbers. One of the other observations to make from the paper that may have been lost if those of you who looked at it was there is a difference in learning between SPECT and PET. And I think this is fascinating and perhaps deserves more investigation and research into. But you can see here for some stress score that competency, as we said, was achieved after 600 studies, whereas in PET, competency was achieved only after 250 for this individual. So I think that when you consider why that might be, I think it demonstrates that there's fewer artifacts in terms of soft tissue attenuation artifacts with PET. I think that the presence of coronary calcium on our PET CT attenuation images can really help specificity. Obviously, blood flow can also help you to determine a normal versus abnormal scan. And I think also, with our blood flow FlowQuant program, it may be easier even to determine the degree of LV ischemia more accurately. So I think that I do believe that this is true, that actually fewer studies are needed and the learning curve is different for PET than it is for SPECT. So the implications for this paper, I think is that CBME is feasible in nuclear cardiology. I think there is a relationship between the number of cases that we are exposed to, or we allow the learners to study, and achievement of competency. Those the definitions of competency, though, I think, as I've showed you, are important in terms of helping us to define the number and therefore time that it requires for training. Provocatively, this study suggests that current guidelines may be insufficient to achieve competency in the majority of cases. Of course, this is a single center study, and it may be in your own centers that the learning curves may be much sharper, with a much accelerated improvement, and so they may not need quite as many studies as our fellows or residents did. There are some discussion points, I think, just generically about CBME within nuclear cardiology. I think the type of technique that we've shown does enable you to spot slower learners. I think I've highlighted this individual here, not to keep picking on them, but just to show there's this slow growth initially, then there's something happens here, and one would hope that perhaps this is when he met Dr. Ruddy, and Dr. Ruddy helped him to improve his learning tremendously, and then it took off. So the idea is that we can spot these learners, we can improve trajectories. Overall, as I mentioned earlier, I think CBME is not just about learners, but I think as teachers we can learn something too. We can direct our teaching to be more focused, to spot what are the issues, what concepts are not being grasped readily by these individuals. And I'm mindful here. We see our specialty is not just perfusion imaging. We've seen some great slides in sarcoid and infection, and I think those areas in particular are quite nuanced learning ideas and concepts, and very different from perfusion. I think they need very specific teaching methods. Ultimately, whether it's learning or teaching, the goal is to produce people who are fantastic at interpreting images and putting them into clinical context, and that's what one hopes is the end product of CBME. Either way, I think this type of learning does help to install enthusiasm in our learners, so that there is a clear pathway for training, and begins to speak to those comments that Dr. Zarat had mentioned. The beauty about the tablet procedure that we used here is, I think that should be adoptable by many centers if there was a will. This is the last slide. I just wanted to really wind up by saying, I think that all being said, I think there's a lot of challenges for us as we seek to teach our new generations of learners within nuclear cardiology and cardiac PET. I think there is an increasing toolbox within SPECT imaging, SPECT CT, we've got blood flow we want to hear about, there's amyloid imaging you've heard about. But not only that, we also have the additional modality of cardiac PET, and within cardiac PET, it's not just about perfusion imaging. You've heard about viability, you're going to hear about infection and inflammation imaging. But many of our trainers also train in other modalities, so their time is short. So I think our goal-directed teaching is important. The last point, of course, is all this about numbers and times and competencies doesn't really touch on mentorship. And I wanted to close really just by talking about the anatomy again of the learning curve, and just point out that for sure, I think we all recognize this advancement from novice all the way through competency to automatic expert. And the idea of the automatic expert is they kind of coast through their career, they've been trained, they can read images. What we ideally want through mentorship is to create deliberate experts. And as one of those gentlemen that we're celebrating today, I think that what deliberate experts are, and Dr. Wood is a great example of this, is there's this continued effort throughout a career to learn more physics, to learn more understanding of cameras, to learn more about traces, to learn more about how different patients' images will be produced. And that's at the core, I think, of mentorship. And I'm not quite sure yet how we do that within competency-based medical education. Thanks very much for your attention.